When you think of a person with frailty, what comes to mind? Is there something you can see? Stooped posture, mobility challenges, weakness? While frailty can present as physical signs, these are only part of the bigger picture. And in fact, sometimes you just can't tell based on appearances. Consider the following scenario. You're working in Emerge, and 3 different patients come in to be seen. The first has a new onset of delirium. The second has come in because of a fall. And the third appears to be dehydrated from poor oral intake. As you continue to work up all 3, you discover that they have the same problem: viral pneumonia. However, what surprises you is that none of them have typical symptoms like chest pain, cough, or fever. As it turns out, there is something more than pneumonia that all 3 of these patients have in common. As we go through life, we all experience health issues. When we're otherwise healthy and resilient, these issues come about, but are short-lived, and then we recover. But as time marches on, sometimes these issues don't resolve and become silent, chronic realities. In other words, they become deficits. During our day-to-day lives, we rely on built-in reserve to compensate and lead otherwise normal lives. This reality of living with these silent deficits is called frailty. Where frailty becomes a problem is under stress. A stressor can be an illness, surgery, or even a personal loss. During these times, reserve capacity is tested, and with less resilience, these deficits present problems. However, by identifying frailty before an acute stressor occurs, we can anticipate and even prevent frailty-related morbidity and mortality before it happens. Returning to our 3 admitted patients with pneumonia. Imagine the following scenario, but this time, if they presented earlier to primary and interdisciplinary care. It turns out that our first patient had been developing a cognitive impairment before this acute stressor of pneumonia. While he was still able to compensate for this impairment in his day-to-day life, dementia is a risk factor for developing delirium during illness. Had this cognitive impairment been identified before, we could have helped him and his family caregivers put in place some delirium prevention strategies, like an exercise regimen, hydration maintenance, and ongoing family support. Our second patient has been unsteady on her feet for several years now. An increasing sedentary life and deconditioning has predisposed her to the pneumonia that precipitated her current presentation. But tripping over a wire or slipping on a loose rug while hurrying to the washroom could have just as easily brought her to the hospital. Had her mobility challenges been identified earlier, she could have been outfitted with a proper mobility device and sensible shoes, minimizing her risk of injury, or an alert system to get help if she falls. Our third patient has actually had dietary red flags over the past year. Had she been asked about it, she would have reported that her clothes have become baggy in the past few months. Perhaps with the proper dietary assessment and interventions, this acute event could have been avoided altogether. Cognitive impairment, mobility challenges, and dietary concerns are just 3 of the many domains that make up frailty. And these 3 cases highlight the multidimensionality of frailty. Frailty-inclusive care is the practice of including frailty screening and interventions in a patient's primary care. By identifying the deficits that a person is living with, safeguards can be put in place and ultimately empower patients to age with dignity, grace, and independence. For more information on frailty, visit the Canadian Frailty Network. For a frailty screening assessment tool, visit our website for the Edmonton Frail Scale.